Welcome back. We're continuing with the Fatal 4 training, and this topic is on seizures. Again, you should have a handout in your packet that follows the slides as long as we talk. I'm Barb Barlow. I'm an RN for seniors and people with disabilities. The definition of a seizure is a sudden, excessive, disorderly electrical discharge in an apparently healthy brain. There's a variety of causes, medications, electrolyte imbalances. In small children, infants, it's frequently fever. Any one of us has a 10% chance of having a seizure at some time in our life. Now let's look at the definition of epilepsy. It differs significantly and yet has similarities too. Epilepsy is sudden, it's recurrent, it's unprovoked, and it's a seizures that occur in a brain that has an injury. We talked about a seizure just being a sudden, unprovoked electrical discharge, but epilepsy is recurrent, so it happens over and over again, and it happens in a brain that has had an injury. Epilepsy also goes by the name of seizure disorder. About 50% of the individuals with epilepsy, in about 50% of these individuals, we can't really determine the actual injury that they have or the cause of their epilepsy. The anatomy for seizures is pretty straightforward. It's the central nervous system, the brain. Let's look at how individuals with disabilities may be at risk for seizures. Some may have injuries prior to or around the time or shortly after birth. They may have injuries caused from trauma with a traumatic birth, poor oxygenation, or they may have a brain infection at about that time too. Later in life or in infancy, they may have traumatic head injuries. This can be anything from a fall to a motor vehicle accident. Sadly enough, it's often abuse or sports injuries. They may have a stroke, a clot in the brain, a brain hemorrhage, or an aneurysm. They may have tumors, or they may have an infection such as meningitis or encephalitis that affects the brain. There are certain seizure types that may pose a much greater risk for some individuals than other seizure types, or for all individuals. Seizures where individuals lose muscle tone and may fall pose a serious risk. Also, seizures where the person loses consciousness and may aspirate. In the top two categories, you're going to talk about the tonic-clonic, also known as grand mal seizures, clonic seizures, atonic seizures, also known as drop seizures. Now, the myoclonic seizures that are frequently jerking usually are so brief that they don't cause this problem of loss of muscle tone and loss of consciousness, though they can. And the third category of seizures where the individual may be pose an immediate danger are seizures where awareness of their surroundings are lost. They may walk or run or climb into unsafe areas. This individual doesn't lose consciousness and fall to the ground limp, but they aren't in a totally alert state either, and they do not know where they are. Particularly of danger is when they are in an area such as a staircase. They may not be stepping well and they may tend to fall. Some seizures have an inherently low risk of falling or aspiration or injury, and those are the absence or petit mal, a typical absence seizure, or an atypical absence seizure, or the simple partial seizures. Let's look at how we can identify people with epilepsy and the risk they have. The first one is just as straightforward as it can be. Do they have a diagnosis of seizures, seizure disorder, or epilepsy? Again, that's not the same thing as a one-time seizure when they were 3 months old, but seizures. Do they take medication for seizures or epilepsy? Keep in mind that medications that at one time were given solely for epilepsy are now also given for bipolar mood disorders and nerve pain, so you need to know the reason they're taking the medication. Have they had a seizure in the last 5 years? And further risk identifiers, here red flags actually, And the red flags are time to be particularly alert with your individual and tuning in to what's happening and monitoring them very carefully. And that's when they're having an increase in the number or the intensity of their seizure. So they're either having more seizures or the seizures are more serious, lasting longer than they used to. In cases like this, their physician or neurologist would need to be advised. They're having repeated minor injuries or you suspect aspirations as a result of the seizures, we need to start looking at what needs to be done to protect this individual. Are there certain safety precautions that we need to initiate? Do they have a significant risk for aspiration that needs to be addressed? They may have illness with vomiting, which can lead to dehydration, or they may be not taking their medications. So with vomiting, they may be vomiting their medication, or they may be vomiting enough fluid or stomach contents so that their medication is no longer diluted in the normal amount that's expected in the body. And individuals not taking their medication pose a particular problem too. Now, an occasional refusal to take a medication is different than a pattern. So certainly we all have to deal with those occasional times when someone doesn't get a medication or doesn't get it on time. But even more serious is the pattern of refusals. And you may need to call an ISP team meeting and discuss what can be done for this individual to make it more palatable for them. Perhaps you can change to a different form of the medication. Perhaps if it's they're giving them a tablet, maybe it also comes in a liquid form that's better, and maybe that particular medication, they don't feel well afterwards, they don't like some of the side effects, but can't tell us. Perhaps the doctor can suggest another medication, or perhaps we can just brainstorm and come up with some creative ideas and ways to make it more tolerable for them to take their medications. Further red flags would be, we already talked about the pattern of medication refusal, or it's a change or a difference in their seizure activity. Now, it's normal for seizure activity and frequency and the pattern to change over time. When this happens, we need to be alert to it and notify the physician. The reason being is that seizure medications are prescribed based on the type and the severity of the seizures they're having. So the physician may need to alter the medication in some way. Another concern is that, excuse me, if we're not adequately documenting seizures and no one is reviewing that data on a regular basis, it's very important to keep track of the seizures an individual has, again, because the physician will be basing some of his or her decisions on this. So we not only need to keep a good record, we need to review it so that we can call them in a timely manner if there is a change. Inconsistent documentation poses a problem too. If we're really alert and astute about monitoring and documenting seizures one month and not the next, it's going to look like they're having an increase in seizures when actually they're only having an increase in documentation. So we need to tune very carefully into that. Whenever the physician is changing medications, usually starting a new medication and tapering them off of an old medication, that's the time you need to be extra vigilant. Because as the one medication is lowered, it may be going down before the new medication's level is effective and has come up enough to protect them from seizures. So you're having one medication drop, the other one coming up, and you may have a gap in here where they're not covered effectively with anti-epileptic medications. Let's talk a little bit about day-to-day safety things that we can do on the next slide. And a lot of ISP teams have had good discussions around these. What can be altered in the home, the work, the community, the school environment to make things safe for people? Should they be wearing a medical alert tag? Are they spending too much time on a cement or hard floor where they may have a fall and a more serious injury than they would on carpeting? Are they traveling on stairs quite a bit without assistance and may have some potential for injury? Are they around furniture with sharp corners and edges? At work, are they operating some equipment like on a grounds crew that may be dangerous for them? A lawnmower even when they're having the potential for seizure activity. Perhaps they need to be using equipment that's not so dangerous. We need to consider their whole environment, not just their home, all of the places they are when they're out in the community. If they're biking, do they need to be wearing a helmet? Oh, they always need to be wearing a helmet, but do they need to be wearing knee and shoulder pads? What else could we be doing for this person?